Okay, it looks like we have a good amount of people in here and just a couple more people outside getting masked up. I'm going to go ahead and introduce the next speaker because we're going to get to move in this session. So it's really going to be like another break, but with movement. Was it? Okay, so I am excited to now introduce Dr. Mai-Hung Ho-Tran, and who's been practicing physical therapy since 2002. So she is currently the lead PT for Kaiser Permanente's Northern California region in chronic pain, and she's the new director of the Pain Fellowship for EIM. A lot of your people are here. Her experience also delves deeply in mindfulness, yoga therapy, Tai Chi, somatic movement retraining, and spiritual direction. She is a mother, yogi, runner, an agent of change, and a lifelong learner. So please welcome Mai-Hung.
Hi, good afternoon, everyone. You can see and hear me okay? Yeah. All right. You know, I thought I was going to be a little bit more nervous than this, but I've got this bright light shining in my eye, so I can't really hardly see you anyway. So this afternoon is going to work out really, really well. Again, my name's Mai-Hung. There were a couple of hand claps a little bit earlier, and Sarah said, "Oh, you got your people here?" I turned to her and I said, "I don't know these people from shit." But thank you for being here. You know, I find that people who come to conferences are highly adaptable. They are anything goes. So let's put that theory to the test. I dare you to pick your favorite movement, whatever that is, a heel raise, a squat, arm lifts, whatever that is, and to stand up and do it for 10 whole seconds. Ready, go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Freeze. Freeze. Some of you have a little difficulty following directions. Freeze. In the position that you're in, notice. If there's any discomfort, lean into that. And in the next 10 seconds, I dare you to move like a sloth. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Freeze. And in the last 10 seconds, we are going to try to put in our minds what moving on wobbly joints would look and feel like. Ready, go. 1, 2, 3, 4. Oh, that's good. Ooh, I like that. Ooh, look at those hips, baby. 7, 8, yeah. 9, yes. Have a seat. It's just a small movement practice, but does it pique curiosity? Does it engage? Does it make you want to know more and pay attention and perk up a little bit more? And I think that that's a large part of building Therapeutic Alliance. Whenever I have the opportunity to be in a space like this, just a side note, if you were listening to Sarah's description of what I've done with my life, it pales in comparison to the list of speakers that you have on your agenda, right? So I think of this as just the opportunity for us to be colleagues with different disciplines, sharing and learning from each other, and really not resting on our laurels, pushing ourselves just a little bit further each time. And it's my own personal belief and practice that how do we accomplish that? The better we know ourselves and how we respond. There was a question this morning online about reconciling and acknowledging our own traumas and journeys that help us better recognize it, teach it, and therefore shift that information from the research world into practical clinical application. So this afternoon, I apologize ahead of time that we're not really going to stick to this script word for word. We might touch on it a little bit, right? Because the different clients that you see when you come back on Tuesday, they might be a grad student in her second year working on a PhD project. They might be a college student, you know, with low back pain because he's been challenged every single Friday to ride the mechanical bull at Double Deuce in Old Town Sacramento, right? But I use that example not in fun, but have you thought about more than just his mechanical low back pain? Have you thought about the pressure that he's getting from rush period if you've been in college, right? And have gone through the rush period in sororities and fraternities, and the amount of pressure that these young men and women are facing. So we might not necessarily go through everything, but in order for us to speak that same language, it's important that we understand pain classification and how we might use that language to become as similar with each other as possible. We might talk about some resources and optimization, and finally, really knowing ourselves best, taking a look at self-care and burnout. This is hands down one of my favorite quotes. How do we, not only for ourselves as clinicians, but also for the clients that we work with, William James said, use pain neuroscience education to make the nervous system our allies and not our enemies. Right, let that marinate for just a little bit. Make it our allies, something that we walk alongside with and not something that we're forcibly fighting against. Right? We know that in as short as 12 months of experiencing long-standing, consistent, constant, persistent pain, have you noticed that I haven't used the word chronic once yet? Right? Because even in language, it lights up a different part of the brain depending on the choice of words that we intentionally use. We know that within the first year alone, the brain actually shifts the areas and the neurocircuitry with which it processes pain. And it goes from this nociceptive sensory pattern that this kills me every time I say this, to a cognitive reward circuitry. Can you imagine that you're getting rewarded because you're in pain? Cognitive reward circuitry, right? And the gray matter itself actually atrophies equivalent to about 10 to 20 years of actual aging. Yeah, right? We know that pain does not exist in separate silos. But let's give ourselves a framework to start with. And we know from Keith Smart's work, I just have to give him a little shout out. I had the opportunity to see him speak via video conferencing last August. And he is just a brilliant man. And I know this is being recorded. He's also wonderfully handsome too. He said, total serious face, right? He says that could we categorize pain in nociception, right? Do I have permission to come up to you and give you a pinch? She's gonna say no. But if she said yes and I pinched her, ow, there's a source to that. That's nociception. Then you might have pain that radiates from a source. So we might call that peripheral neurogenic. And this is a much more dermatomal or cutaneous distribution, right? But there's still, you can still pretty much see that A plus B equals C in these first two categories. And then in the third category, what used to be called central sensitization, and more so it's being called nocioplastic, is pain is often diffuse. There's often not a rhyme or a reason to it. And in the olden days, when this work started to come out, the description was that there was some psychosocial factors more in this particular category than in the first two. And then in 2012, Shraim et al. Said, you know what? I really want to ask the experts. I want to ask my expert right here if she were to categorize pain and all of the characteristics that that involved, what would she list as descriptors under these different categories? And it's a really quite a wonderful article. I would recommend that you put that on your list of things to read. And I'm not a technological person, so I did the best I could, but hopefully you can see that for the nociceptive circle, A plus B equals C. Makes sense. But when we actually look at the other two categories, they were so similar that for the nocioplastic and peripheral neurogenic categories, that the characteristics that defined these two categories were so similar that in the treatment process, it would behoove us to really take a much more open therapeutic alliance biopsychosocial approach. A large part of that, as we've learned so far already from the amazing lineup of speakers, is that one-to-one education. Really calling the patient for their functional impairment. You know, are you the kind of person that if you do something and it hurts, you just progressively stop moving more and more over time? And even in your motivation centers, you move away from that particular activity. And this is what we call the excessive resters in the clinic, right? And this is something that I actually spend time teaching the patients. We're talking about these different spiraling cycles. And the other cycle that we might talk about is that boom and bust cycle. Might go big and then go home, right? And in this particular setting, we often see overexertion followed by periods of rest and recovery. And as we're going through these pieces, I'm going to ask you to do the same thing as many of our speakers have done so far today. Sit in that uncomfortableness if any of this resonates with you. If you find that, well, yeah, that's definitely me, that pushing through it cycle, that's me, right? Sit with that and notice what that arises in you as you sit with those different concepts. So I want to be able to communicate that well with you. So in my assessment, I might address that specific thing, that this patient presents with signs and symptoms consistent with which one of these categories, and their functional impairment is consistent with which one of these presentations. That's what all of those words up there say. Any comments, questions, or concerns so far? All right. So what do we do on day one? I'm going to invite you at this time, if you feel comfortable with it, only if you feel comfortable with it. Isn't this scary to have a speaker walk down the aisle and be next to you? Oh my gosh, is she going to call on me? I'm going to invite you to either stand or sit back and recline. I mean, totally slouch. Let your pens, laptops go. And the first thing I'm going to ask you to notice and pay attention to is where your breath is this afternoon. Perhaps it's in your nose. Perhaps you notice it in your chest. Perhaps you notice it in a particular body part. What temperature is your breath? Even for those of you at home, in the comfort of your own homes, make sure that you're comfortable. You have the ability to lie down, so go ahead and do that. And just notice, just take a moment to actually stop, be present, be still, and notice. What color is your breath, if it was a color? And how long is your breath? If you could count how many seconds it takes you to inhale and how many seconds it takes you to exhale, what would those numbers be right now? Whatever those numbers are, we are going to practice mindfulness and non-judgment. We're just going to notice it for what it is, and then we're going to encourage that breath to be longer on the exhalation. So for example, if I find myself breathing in for 4 counts, my exhaling breath might be 6 counts. 1, 2, 3, 4, 6, 5, 4, 3, 2, 1. And I would encourage you to continue breathing in that pattern as I give you 2 more short instructions. See if you can notice a natural pause that occurs at the end of your inhaling breath. And it's going to be different for everyone. And see if you can notice that natural pause at the end of your exhaling breath as well. Okay. So you're going to inhale, pause, exhale a little bit longer, pause. And this time, when you do it again, extend that pause a little bit longer. So we might do 4, 3, 6, 3. Here we go. Inhale, 1, 2, 3, 4. Pause, 1, 2, 3. Exhale, 6, 5, 4, 3, 2, 1. Pause, 1, 2, 3. Again, inhale, pause, keep holding. Exhale all the way through, pause. And now let your breath go completely. And as you come back to your regular breathing, I'm going to ask you to notice, what does that feel like in your body, in your respiratory system? What does that feel like in your chest, your muscles, your circulation? What does that feel like in your mind? You've just gone through a very simple breathing technique of the continuous or cyclic breath, and then the addition of that pause called the ratio breath. And the science shows us that when we start from that continuous cyclic breath, moving into noticing that pause in the diaphragm, and then moving on to the harder ones, the box breathing, 7, 8, 4, all of the other beautiful ones that we do, that transition, that graded exposure can be much more inducing of feelings of safety for someone, especially someone who perhaps is a little nervous about movement. And isn't breathing movement? One of the things that I often remind my folks is everything you do counts. Everything counts. Every movement counts. Because why are we spending so much time on breathing? What's the benefit of this? We know that from the metabolic reflex response, that if you were ever in a situation where your body had to decide between keeping the muscles moving or breathing so you don't die, what wins every time? That you don't die, right? That you're going to stay alive and breathe. So we want to encourage the fact that, hey, moving is safe. That moving is actually a safe thing for me to do. So I might take that breath work and then pair it from that ratio breath right into some gentle, mindful movement. So I'm going to invite you at this time to let your phones down again. And I really appreciated the mention this morning. I can't remember who it was, but I think it was our fellow OTs, that when we move, it's really important to consider the whole big picture of a function and what that means to someone. So perhaps for that client that's sitting there in front of you, it's not a squat yet. Maybe it's something as simple as, how do I get off the toilet without being so scared that I'm going to plop back down and hurt my rear again, right? So I'm going to ask you to put your things down, sit back, but this time you're going to make sure that the back of you does not touch the back of the chair. So we're going to make sure that we are a little bit taller. I'm going to ask you to take both your palms and turn them up so that they're resting in your lap. Yeah. This is a beautiful opening position, especially for those of you who are yoga trained or have exposure to that. And in that position, begin just simply by noticing yourselves. Don't follow me around with your eyes, just noticing the presence of your own body, your own mind, right here, right now. And I'm going to ask you to trust this process by closing your eyes. Now, the benefit of closing our eyes is that we now have no judgment of ourselves, of others. It's just you. Nobody's watching you, myself included. I'm going to turn away. In that position of stillness and closing your eyes, I'm going to ask you to inhale and turn the palms up. And as you exhale, you're going to turn the palms down. Now, this is completely up to you what this looks and feels like, because nobody can see what you're doing. And this is also up to your brain's own interpretation. And trust that the way that it interprets directions is good for itself. Can you now turn the palms down onto the thighs so that as you exhale, you slide the hands forward towards the knees and allowing your spine to round and crumple down, and move in the opposite direction when you inhale. You're going to straighten the spine and pull the palms back up towards the hips. Try that motion several times, and as you do so, I'd like to invite you to scan from the top of your head all the way down to your tailbone. What does this movement actually feel like when I do this? What does rounding and straightening actually feel like? What parts of my body are involved, and what's calling for my attention? And as you come to sit back upright again, bring your awareness down to your left heel. Your eyes are still closed. Bring that awareness down to your left heel. Through the magic of television, we're going to transport ourselves back to the 80s and the 90s where they didn't have backup cameras yet. And we're going to reverse our car, because that was the thing that you asked me about in the evaluation today. I have pain every time I go to reverse my car. So let's experience that. When you're ready, slowly take your right hand, reach it up and over and place it on the back of that passenger side seat and turn your head to reverse your car. Hold there for a moment and notice what happened to my breath. Where is my breath? Did I forget to breathe? Where do I feel this in my body? What body parts, what muscles are calling for my attention? Then as you come back around, eyes still closed, this time bring your awareness to your left heel. When you turn and reverse the car, can you challenge yourself to begin from the ground up? So let me walk you through that. Take your left heel and push down into the floor, and as you do so, see if you can notice that your hips want to unweight and start turning. Then allow that trunk to turn and give in to that trunk rotation, and that shoulder then begins to turn, then the arm, and finally the head and neck, so that it creates this beautiful spiral from the bottom up. And can you challenge yourself to do that while you exhale? While you exhale. So come back to the center, eyes still closed. Take a deep breath in, 1, 2, 3, 4. Exhale, push your heels, spiral, and turn. Come back to the center, eyes open. Just giving yourself a moment to notice what that felt like. You might even notice that, I got to do it to the other side. So you're welcome to try that. Just as I continue talking, bring that awareness to your right heel. Push that right heel down, turn like you were going to reach for your seatbelt or something. Okay? Really being aware of movement sequencing and how we actually practice pacing and the distribution of workload as applied to our bodies. Instead of that boom-bust cycle for one muscle group, can we take that and involve as many muscles as possible? All the while being aware and present of the power of that soothing and calming exhaling breath. As a clinician in this environment, it's important, as we've seen so far in all of our lectures, that we broaden our lens. And I don't think of this, and I will say this formally, I don't think of pain neuroscience education, I don't think of ACT or CBT as a treatment tool. I really believe that it's the lens through which we should approach rehab and care for the folks that we work with. The primary difference between ACT and cognitive behavioral therapy is that ACT really looks at modifying specific patterns, whereas cognitive behavioral therapy is really looking at changing our negative distorted thoughts. So ACT is really asking the individual that we're working with, can they develop and continue to practice psychological flexibility? It's kind of hard to do that if we are not practicing psychological flexibility ourselves. So understanding, I'm going to give you a crash course in acceptance and commitment therapy for PTs. And there's some good research as to why PTs using the lens of ACT can be pretty effective. If you look at this from the left side of the screen over to the right, this middle section that's white, this is not my work. These are the core principles of acceptance and commitment therapy. The white words that you see on the outside, that's my interpretation of it. And as you can see, it's very, very simple because I really take to heart what our last speaker was saying. How can we make this less clinical language and more patient-friendly language? So acceptance is asking this individual to open up. I think a lot of times acceptance has a negative connotation, but can we make it a neutral event? So opening up and being able to really watch your thinking pattern, right? Thinking is not good or bad, it's just how you think about a particular situation. Can you remove yourself and do a zoom out or a bird's eye view and watch your thinking? Can you be present moment and be here now with just this pure awareness of what you're doing? And that movement practice that we just did, for example, is an example of that movement awareness. Can you make it so that every single time, it'll take some practice, but every single time you reverse your car, that you train your body to spiral from the bottom up versus coming from the top down, right? Each and every single one of those movements counts. And as I'm chatting with this particular individual, right, do they really know what matters to them? What are their values? And are they willing to do what it takes to make sure that they continue to hold those values true? I often think of a particular gentleman I worked with a couple of years ago, chronic low back pain, back surgery, all of that good stuff. And his value, his absolute value, was to be able to spend time on the floor with his grandson. So even though he hated it, he verbalized every single time he met with me, I really do not like coming into therapy, but I'm gonna do it because being able to get up and down from the floor safely allows my daughter to see that I can be safe with my grandson. That was the committed action that, I'm involving that particular patient in goal setting. That committed action was what he was willing to do in order to hold true to those values. And the science backs this up for us as professionals and particularly as PTs. You can see all of the wonderful things that are coming out in the research about the use of acceptance and commitment therapy lens through which we practice physical therapy. Is it in our scope of practice? Sometimes I've mentioned this in other avenues with psychologists and whatnot, and oftentimes in that collaborative nature, the question that I get is, are you overstepping your boundaries? This is our code of conduct, and CAPTE says that yes, please, really address this stuff, right? A psychologically informed practice woven with the best biomedical interventions. I want to make an emphasis on that piece. Sometimes the pendulum swings one way and then it swings completely the other direction. There's always balance of both, right? Don't forget your biomedical and clinical manual therapy skills. That is just as good as creating therapeutic alliance. One of the challenges, I think, for us as clinicians, and even for the patients, right? Or maybe ourselves just sitting here as a patient in this room, when there's a new behavior or a new hobby, how do I make it stick? How do I make it last long? There's, I got a thing for handsome gentlemen. Mr. B.J. Fogg. Dr. Fogg is a behavioral researcher out of Stanford, and that's all he does all day long. He studies how people change behavior. And it turns out that if it is tied in to something that exists already, like you have to go to the bathroom, right? Every single time you stand up to zip up your pants, can you do one heel raise? Every single time you go to the bathroom. So it's anchored to something that already exists. And if that moment already exists, it can act as a cue for that particular patient. And you'll notice that I said one heel raise. That task is so small and it's so easy that it's doable. And just like we've heard several times today already, what are the best kind of exercises? The exercises that the patients are going to do, right? It ain't no good to nobody if they're not going to do it. And then finally, what I'd like all of you to do, if you're comfortable, you can stay seated, but if you want to stand up and get a little break, you're welcome to do that. I'm going to ask you to make 2 fists for me, please. Yep, you got your fists going on, right? Ooh, those are some good fighting fists, girl, yeah. Do you know that this is how to really throw a right hook, that when you make a fist, it's got to be nice and flat? Those are my Taekwondo days, good fists. So make 2 fists, and when you're ready, I want you to say, with pasión, okay? I want you to say, I'm awesome. 1, 2, 3. I'm awesome. I kind of didn't believe that. 1, 2, 3. I'm awesome. Stop for a moment and notice. Notice what that feels like in here. Notice what that feels like in here. You know what you just did? You just got a shot of serotonin, right? You just got a little hit. So when that immediate reward happens immediately after that new task or behavior, that solidifies to the brain, oh, that good. I want some more of that. So I'm going to want to do that behavior again. So finding some sort of celebration. For that particular patient, maybe this is too much for them, maybe a self-pat on the back or whatever it is that works for them to really make those behaviors stick and change. A couple of resources for you. And I've gone through a variety of different resources, but when I go through my multidisciplinary classes, at the very end, I'll ask on a survey, what were some of the best resources that you found most helpful? This is no clinical research study. This is just my own asking folks from a survey. These 4 happen to be the 4 that always come up as a result of that particular survey. What is it that you can do? You're doing it right now. So big round of applause to each and every single one of you. Pat yourselves on the back. I'm awesome, right? It's wonderful to get those endorphins going. So being psychologically informed in your practice, your own self-reflection, and sitting in that uncomfortableness if you need to. In 2017, I believe, yes, 2017, a study by Gardner et al. You know, you have certain studies that just like move you and rock your world. This did it for me. This did it for me. And this was the study that opened up my eyes to the need for a more psychologically, socially informed therapy practice. And the study found that your beliefs, your practice, perspective and angles actually helps to determine the functional outcomes of your patients. blows my mind. So that means that if I am a biomechanically modeled PT, that my patient's functional outcomes would be affected. But if I am a more psychosocially informed PT, that could then shift and change their functional outcomes. Blew me out of the water. Application of your own breath work, your own mindfulness and wellness practice, right? And calling it. When I can't do it anymore, my hands are both up, my hands are tied, I give up. That's where I'm pulling in my psychology friends, my social workers. I am lucky enough to be in a multidisciplinary setting, but we all know that even if I was a single silo in a rural area, there are relationships that can be invested in and it would be worth my while. But it's really my personal belief, and I think I see a lot of head nods every time I say this, that when we know ourselves well and we have that experiential knowledge ourselves, it makes us more in tune with the folks that we work with. So making sure that you have that ability to zoom out and take a bird's eye view of the different situations that you're in. Sometimes, we say that, but we don't have any real hard, tangible ways to do that. So I thought I'd just include this graphic up here. This is something that is printed at home for patient use in my own office. So that, if a patient comes in and they say, the thing that I'm really struggling with is my spirituality, my Hung. This is it, right? And so it gives me some tangible ways like journaling. If I know that person is a writer, I might say, let's try a little journaling, which has a lot of research to back it up, by the way. I want to take the last few moments. I've got about 4 more minutes, and I'd like to, if I may, walk you through a short practice that I will typically end my sessions with. So again, pens down, laptops down. And this time I'm going to ask you to remain seated, or if you feel comfortable with it, I think Megan even has her yoga mat with her. If you want to lie down, go for it. This is going to be a Sandy Pain Summit first. If you want to lie down on the floor, you're more than welcome to. And as you come into that space of presence, of being still, I want to invite you to close your eyes if you feel comfortable doing so. And if you don't, that's quite all right. I just ask that you downcast your eyes about 45 degrees, allowing those lids to become a little bit heavier than they were, bringing awareness and inviting attention into the breath once again. Noticing what the breath feels like now compared to 45 minutes ago. We are who we are through a lot of interactions of those who come before us. The wonderful, amazing list of speakers that have gone before me, the shoulders of giants that I stand on. I hold space and gratefulness for them. If it feels right, I invite you to think of that individual, that person who brings you such joy. See them in your mind's eye. And if it feels right, imagine saying to them, may you be happy, healthy, and whole. May you have love, warmth, and affection. May you be free from fear and safe from all distress. May you feel peace and the utmost ease in this day and in the days to come. And as you wish well on this individual, can you notice the physical sensations inside your own body? What does it feel like to wish well upon another? Take for a moment this person that you hold so dearly. Imagine them looking upon you, saying to you, may you be happy, healthy, and whole. May you have love, warmth, and affection. May you be free from fear and safe from all distress. May you have peace and the utmost ease in this day and in the days to come. What does it feel like to be on the receiving end of those well wishes? That those thoughts come in externally. What does that feel like in your body physically? And last but certainly not least, I invite you to look within. Take a moment and see yourself and look upon yourself. And if it feels right, I invite you to wish upon yourself. May I be happy, healthy, and whole. May I have love, warmth, and affection. May I be free from fear and safe from distress. May I experience peace and the utmost ease in this day and in the days to come. I invite you to take one last deep breath in. 1, 2, 3, 4. Exhale, 6, 5, 4, 3, 2, 1. One more big deep breath in through your nose. And as you exhale, open the mouth out wide and say, ah. I wanted to, hopefully in some small way, demonstrate to you the journey that a patient could go through. This is something similar to what I might do in the clinic, to start off with a little humor, a little therapeutic alliance, move into a little didactic education and pain neuroscience education, do a little breath work and pair it with movement that seems graded and safe, give them that hit of serotonin to reward them for their hard work, and then to down-regulate that nervous system to end it on a good note. I thank you for your interaction and being such wonderful guinea pigs. Big round of applause to you.
All right, do we have any questions from online or here in the room? Go ahead.
Make it an easy one.
Oh, hopefully it'll be easy. Thank you for that. Always love a little mindfulness. And my question is, we know that down-regulating breath work is really helpful, but I'm curious to know if there's any evidence on up-regulating breath work and the potential benefits there. Do you know of anything?
I apologize. It's hard to hear you through the mask.
Oh, sorry. I know there's a lot of evidence for down-regulating breath work, and I was just curious if there was any studies on up-regulating breath work and if it had any additional benefit, less benefit, any comparison between the two?
I love it. That's a great question. Yes. So in that graded exposure process, just like in pacing, if you take somebody who has no clue how to pace, the first thing you got to get them to do is to even understand that they've got to take those rest breaks, right? And then what you do want to end up eventually guiding them towards is nudging, pushing, teasing, touching the very edge of pain, and still be in that space that, oh, I'm still safe, that this is a sensation that I can feel safe being here too. I think of breath work as just like any other exercise. The diaphragm's a muscle, so there is a lot of benefit to being able to both down and upregulate. Yeah. For the folks who, surprisingly, in the clinic, it's actually those folks that, for myself, my folks with fibromyalgia, my folks with CRPS, that seem to like a little bit of movement because that's all they ever get, right? They're not in a space yet to really get a lot of that aerobic capacity. So one of the things that I'll introduce them to is a beautiful website called sparkpeople.com, Spark, S-P-A-R-K, sparkpeople.com. And they're all seated exercises, and it is practical application of pacing. There's really no repeated movements. And that's something that, actually it was Linda who brought that up on our regional team when we were doing the big movement revamp. So that's another great website for just getting breathing, upregulation, and cardiovascular fitness. Great question. Thanks for keeping it easy. Any other thoughts? Or just sharing your experience, yeah.
Thank you very much for that. You mentioned that if somebody comes from a very biomechanical model or they come from a very psychosocial model, then the client that they're working with tends to see improvements in the biomechanical or the psychosocial. So in other words, the place that the therapist comes from has a very great influence on their client. You finished your presentation by asking us how it felt to receive your well wishes externally. So those two things have made me wonder, is there research into the role of the therapist's intention in their work with the client?
Dr. Kathleen Luca, I think you found yourself a new grad student. When you know, please share that information. I'm not aware of that. But that really puts a light on that perspective, right? So I would love to know that if I had some issue, right, and I go to a Tai Chi trained therapist, right, a body worker, what my functional outcomes would be if I went to a yoga therapist instead. Yeah, that's really, really interesting perspective and question. Yeah, I'd love to know that. Thank you. Yeah. Thank you for your participation.